lighthearted. When I lecture to the PT students, it's very informal, so please, if you have a question, if something that I'm saying doesn't make sense, please stop me. You may have to wave your hand around because I don't have my glasses on because it makes it easier for me to see the screen. It means like you guys are a bit fuzzy. But just stop me and we'll try to make sure everybody understands what I'm talking about. All right, so these are the things we're going to cover today. We're going to cover the integumentary system, what we do with minor burns. We're going to talk about venous insufficiency, probably more than the other things, and that's because 70% of the wounds that are treated are venous in nature, so we need to spend a little bit more time on that. Arterial ulcers, they're just hard to deal with, so we'll talk about that a little bit. We got another category, and then we'll delve into pressure injuries or pressure ulcers. So, wouldn't it be nice if this is what all skin looked like? But it doesn't. But if you have a wound that is partial thickness in nature, those wounds heal by re-epithelialization and regeneration. And in that type of a wound, one that's fairly shallow, the normal function of your skin returns. Okay, so you don't have a scar, and all the properties of normal skin come back when that wound heals. Those are usually closed somewhere between 10 and 14 days. And epithelial cells, or the outer skin cell, can come either from the edge of the wound, or if there are hair follicles still present in the wound, the epithelial cells can also come from there. So these would be things like if you have a child that falls down and scrapes their knee, or if you have someone who maybe takes the plastic off of a microwave dinner and they get a steam burn to their hand. Those are the kinds of wounds that are partial thickness wounds. Full thickness wounds are a little deeper. The normal function of the skin is lost when this wound heals up. As these wounds go through these phases of healing, they can sometimes get stuck in these various phases. So the first phase is at an inflammation phase. This is the phase where a lot of our physician colleagues believe that a wound is actually infected, okay? And that is not always the case. We need a wound to be in an inflammatory phase because that starts the whole healing cascade. And sometimes, as wound care providers, we have to take a wound that has become chronic and we actually have to do something to that wound to push it back into that inflammatory phase so we can start this whole healing cascade again. But this is where you're going to have some drainage, some redness around the wounds are painful, and so it does get mistaken for infection at times. Then we move on into the proliferation phase of healing. That's where these wounds usually have some depth to them, and the proliferative phase of healing is where that wound is making that tissue and filling it up, okay? So a wound has to fill in the depth before the skin cells can slide across the top, all right? So then once that wound is full of nice red beefy granulation tissue, then those skin cells migrate from the edges or come and re-epithelialize that wound. Then you have about an 18-month period of maturation and scar remodeling, okay? So these are the things that are happening in that inflammatory phase. It begins immediately, can last up to 7 days. This is where you have the bleeding, so you want that to stop. You want to clear away the bacteria. And as I said, this is a normal response. Then in that second phase, the granulation phase, fibroblasts are coming in, they're making collagen. We have that capillary inflow, those little red buds. And in this phase of healing, the oxygen and nutrition demands are high. So if we have a patient that has a large wound, then we may ask our dietitian friends to come and talk to them about what they should be eating, how they can help us with healing that wound. This is just to show the epithelialization of the wound. This particular phase will overlap with the proliferative phase, and it continues from the edges of the wound. Okay? Here's a good picture of a scar just to remind us that even after a wound is closed, the wound is still working. It's remodeling, things are changing, that scar is flattening and maturing, trying to get that scar tissue to lay down in less of a random pattern and more of a pattern where the scar won't be so ropey and thick. And like I said, this goes on for a long time. With our kiddos with burns, this is important for the patient and the family to understand that this really goes on for up to 2 years. All right, so what are some things when we get a patient in to do an evaluation, what are some things that we're looking at as physical therapists when I see a patient? I want to know a lot of things about what has gone on in the past and what have they tried, and in their opinion, what do they think is helpful and what do they think has not been helpful. Because it doesn't make any sense for me to have somebody who's referred with something that the physician team is calling a chronic wound, and for me to start right back with the things that the patient has already tried, or the home health company has already tried, or the other wound clinic has already tried. I need to eliminate those things and see what I can do that's different than what's been done before. So there's some things that are intrinsic that are related to the patient's general physical and mental condition. So I want to know, is it an older patient? A lot of times with the elderly, we'll find that their healing times are just so much longer than kids. We had a couple of our children's physical therapists that went on to do other things in the spring of this year. And so I was covering the children's wound care clinic on Monday and Thursday afternoons. And I hadn't done a lot of that lately. And I was amazed by the difference in healing times from my 80-year-old patients versus my 8-month-old patients. You know, you get an 8-month-old that comes to you with a burn that's, you know, not large and not deep. You can't even, they'll be well before you can have them come back in the clinic. Whereas for my 80-year-old patients, that's certainly not the case. Kids just don't have a lot of the comorbidities that our older patients have. So if you have patients that have other chronic diseases like diabetes, hypertension, arthritis, like rheumatoid arthritis where they have to be on steroids, all those things impact their ability to heal, and we need to take that into account as we're setting our goals. So if I have a child who has a small burn, I might have a goal that that patient will be healed in 2 weeks. Whereas if I have that same burn on someone who has a lot of those comorbidities, it may be 2 months. And you guys may or may not understand that our documentation or reporting is reviewed by the insurance companies, and it's not always reviewed by someone who knows anything about medicine. And so if I write my goals for the wound to be healed in 2 weeks on the 80-year-old and that doesn't happen, then I've got a lot of explaining to do as that treatment goes on and on and on. So it makes sense for me to have a good understanding about what I think is going to happen so that I can have some realistic expectations as I set those goals. So chronic disease, anyone who has immunosuppressant for any reason, if they have sensory impairment like our patients with diabetes that have neuropathy, or our patients that have some sort of a spinal cord injury, if they have sensory impairment, that is going to slow healing. Okay, so if you can sit on your pressure injury and not even know that it's there, you are not going to offload it. So if I let you guys sit here in these seats for 2 hours while I talk, you're going to wiggle and move because your bottom is going to get tired of sitting. If you don't feel that, you're not going to move. So you can see that if you have the same wound as someone with a spinal cord injury, yours is going to get better faster because you're going to get off it because it hurts. Tissue perfusion is another big, big thing. So like I said, with the kiddos, they don't have the comorbidities, but if you have a patient who has diabetes and they haven't been in good control, they may have good macro circulation. So when you reach down to palpate their pulse, you may be able to feel that. but a lot of times where their tissue perfusion problems come in is in that microcirculation, so in those capillaries. So even if you do an ankle brachial index on a patient with diabetes, a lot of times they have calcification of the large arteries, and so that ankle brachial index, which is a measure of their blood flow to the limb, is not typically accurate. And without a referral to the vascular lab or someone who performs some different studies, you're not really going to be able to know what that patient's ability to heal is. So just some things to take into account. And then also just looking at the wound. Is there a lot of necrotic tissue in the wound? Are there foreign bodies like suture material that the team is not ready for you to remove yet? All of those things will negatively impact the patient's ability to heal. And thinking about when you're documenting this, one thing to remember is if there is a lot of necrotic tissue in the wound, be sure, I don't know how you guys' documentation goes because I am not a PA. But for us, we have to make some sort of an assessment of the wound. And so in that assessment, what I'm going to say is something to the effect of, due to the presence of a significant amount of necrotic tissue in the wound bed, anticipate that the wound will become larger as it is fully debrided. Okay? Because again, when that person is looking at those notes and they see that the wound measured 6x3 on the day that you started, and then 2 weeks later when you've got it fully debrided and now it's 7x4, it would look to the untrained eye like that wound was not improving. But when you look at the wound photos and see that it was covered with yuck at first, and now it is nice and clean and beefy red, we know as medical providers that it is busy. It is better. But it is important to put that in from the get-go because everybody doesn't know that to be true. Okay, we doing okay? Too fast? Too slow? Just right?
Just right.
All right. Okay, so what's going on outside of the patient? What kind of medications are they on? So we mentioned steroids, that's one, but the list of side effects from the medications that these elderly folks take is as long as your arm. And so we've got a couple of pharmacists that are really great for us to bounce ideas off of because a lot of times those medications are keeping these folks alive, literally. So it's not like we can say, hey, would you stop taking your XYZ for a couple weeks while we get this wound healed? Because that just doesn't work. So we have to figure out how can we work within what we have to be able to make this wound move to the next phase. How is their nutrition? This is one that my staff and my students, in my opinion, probably neglect the most. Okay, hospitalized patients not so much, but those that come to us as outpatients, especially older women. So when you ask them about what it is they eat, do you eat 3 meals a day? They will say yes, but don't leave it there. Go ahead and ask them, can you give me an example of what you had for breakfast this morning? Okay, if they tell you that they had toast and black coffee, to them that is a meal, okay? But if you have a large wound that you're trying to get well, toast is not going to get you there, okay? You've got to have some protein. And they really have a hard time understanding that if they went out to dinner with their family the night before and they had a big steak, they're like, well, I had a steak last night, but they don't understand that whatever that they didn't use right away doesn't get stored as a steak, does it? It gets stored as fat. So they've got to have that protein, and they have to have it several times throughout the day, okay? Protein is what breaks down into amino acids. Amino acids go through the circulatory system, if they have a good one, to the point of the wound, and that is how tissue is formed, okay? So those key things of, are you getting what you need nutritionally, and can you get it to the site of the wound? Okay, so do you have the flow? Do you have those products available? So I will tell them, you know, I'm not a dietitian, but I've worked very closely with them for years and years and years. We've got lots of great handouts. But a lot of times, older patients just don't understand what is a good source of protein. So we've got, handouts that we give them. We want you to be eating, your meat, your fish, your chicken, your peanut butter, your yogurt, nuts, cheese, all those sorts of things. And we really try to get them to have 3 meals and 3 snacks if we can get them to do that. Some of the older ladies that are tiny can't get that much food in, but that's what we shoot for. Okay, our oncology patients. How does chemo and radiation affect what we're trying to do? Problems with chemo and radiation is they're not very selective, okay? So they take out everything. They're getting better, and some of the issues around radiation are that if someone is getting radiation treatments, it's usually 5 days a week for, most start with 20 treatments. If they begin to get burns from the radiation, those are really, really hard to deal with because you can't put any kind of ointment on because it has to be completely removed before they have the radiation treatment the next day. So you can see if you have an irritated area, almost like a partial thickness burn, you don't want to put something greasy on there and then have to scrub it off. So it really makes it hard for us to help these folks while the treatments are ongoing. But there are a couple things we could do. But anyway, the problem with these things is they just really aren't super selective. So they will, a lot of times, take out, the radiation will take out a lot of structures in the general area. And the chemo just zaps everybody, takes out, a lot of things in the bloodstream that we need for healing that it just tears apart. It also makes people, just very tired, and so they're not up and around. So if they are frail and fragile and malnutrition, then it can be enough to, in fact, I saw a gentleman yesterday that is taking chemo every 2 weeks, and he just doesn't feel like getting up, and so now he has a pressure ulcer on his sacrum. He knew he was getting it. He's got a PhD. It's not like he wasn't a man that understood what was going on. He just couldn't make himself get off it because he just felt so bad. So I think we got him turned around and going in the right direction. And stress can affect healing. You can see this by looking at cortisol levels in folks that are in the hospital. Those levels will be very, very high. Stress can, even positive stress, can affect healing negatively. So you just have to have a really good history with these patients, understand what's going on. And then, of course, the one we're all familiar with is bacteria or infection. Those things will always impact healing in a negative way. Okay, iatrogenic things. Things that maybe we can have some effect on. Okay, so we've talked about blood flow, local ischemia, knowing how to do an ankle brachial index, checking your pulses, things like that, knowing who to refer to when those things aren't where they need to be. How do you get that turned around? Are there things that you can do? For me as a physical therapist, if we have a patient who has a wound on their leg and it's not to the point where they want to do a bypass or they want to do a stent, there are things that we have available to us, modalities we call them, that can increase blood flow to the limb. So one of them is what I'm doing right now. If I walk around, my muscles will not work without blood flow, okay? So you guys all know what claudication is? Okay, so we will ask these patients to walk to the point where they begin to feel that pain coming on, and then rest, and then do it again. And what will happen is the collateral circulation will form in the limb to feed those muscles because you're pushing them to the place where you've got to have blood to do the work. So that's one thing we can do. We can use, they have these pads in the hospital that are warm. We used to call them K-pads. I don't know what they call them now, if they even call them the same thing. Or we have hot packs. We can put that in the groin, where the femoral artery comes close to the skin. And what will happen is if you put that there and warm it, then you will have a vasodilation of all of the arteries in that leg. So that's another way to bring more flow. We also have modalities called electrical stimulation that we can put either in the area around the wound or, again, on places where, like the popliteal fossa, where the artery comes close to the skin, and we can cause the more dilation and get more blood flow that way. So we have a few tricks up our sleeve as PTs. Another thing is, what are you going to clean the wound with? We've probably all heard at this point that we used to use a lot of betadine in wound care when I first got out of school, and we irrigated with betadine, 10% strength, and we would also cover gauze with betadine and put it in the wound. And now there are studies that show that that is cytotoxic, and we shouldn't do that. So now there are things to clean with that are called wound cleansers, and they are supposed to be at the correct pH for you to be able to use those on a wound and not cause trauma or not kill off fibroblasts. But as I told my PT students 2 weeks ago, that doesn't mean that there's not a place for some of those things that we used to use, okay? You just don't want to use it every single time. Peroxide is the same way. We just had a patient, I think it was not this week that I saw him, but last week, said, well, how are you taking care of it at home? Well, I peroxide it 4 times a day. And I'm like, well, yeah, that's why it's still there. Peroxide is fine if I fall down out in the garage where my husband and my son have lots and lots of yuck. I'm going to probably peroxide out that first time. But after that, I shouldn't need it once the wound is cleaned up. Okay, now having said that, if somebody comes in and they have just a nasty, horrible wound that there is not one single bit of good, healthy tissue in that, does it really matter if I use betadine or peroxide on that? I'm not going to kill anything that doesn't need to be killed because there isn't anything healthy there. So just use your head when it comes to things like that. Dacans and chloropactin and acetic acid and all the things that we've used over the years for wound care. I think they were overused 25, 30 years ago, but I think they're probably underused now because people have swung too far the other way. So you just need to understand what they do and understand the indications to use them. You can never go wrong with just normal saline, unless you're using a silver dressing that gets bound by the saline. But for the most part, saline is a very innocuous choice. Okay, so then trauma. So what do I mean by trauma? So I told you that if I have a patient that doesn't have great circulation, I would want that patient to be up and doing something. I'm a PT, so I want every patient to be up and doing something, right? But what if the wound is on the bottom of their foot? So how does that change what I want to do now as a wound care provider and as a therapist that promotes mobility? So if my patient is diabetic, I know that some kind of aerobic exercise is going to help them control their blood sugar, and from a wound healing perspective, it's going to be much better for me to try to heal the wound if the blood sugar comes down. So I want to find something that the patient can do, but probably not walking if the wound is on the bottom of the foot. So sometimes you just have to be a little bit more creative. So do they have a stationary bike available to them? Or do they have an arm ergometer? A lot of older people see that there's an infomercial on that little peddler thing, so they can set that up on the table and use their arms to do that. So there's other things that can be done, but it's important that you're looking at what's going on in a patient's life and making sure that wherever that wound is, they're not inadvertently causing trauma to it that they don't even realize. A lot of times they don't understand the relationship between walking and a wound on their foot, and it's up to us as healthcare providers to make sure that they get it. Sometimes also it's as simple as they're in an offloading shoe, but the straps of the shoe are in the wrong place. So you may just need to go to a different type of shoe. So we see that over and over with folks that just don't understand how these things fit together. And then just what is the extent of the injury? Is it an injury that has been overlooked? For an example, a lot of times in our patients that come to us with a venous leg ulcer, you will ask them, well, did you have an injury? And as they think back, they'll say, oh, you know, this is the leg that I, whatever, you know, was my bad ankle growing up, and I sprained that ankle, 14 times over 10 years. That will have an effect on venous return and also lymphatic return. So again, just a really detailed history on these folks so that you can start to put together the pieces of why this wound looks like it does. We don't usually get any that are real straightforward, so it's like a puzzle. All right, so let's switch gears real quick, and we're going to talk about care of burns. Most of the burns that we take care of at OU Medicine are children. We are the regional burn center for children. Anything that's over about 20% total body surface area does get sent to Shriners or down to Houston, other places. We don't take care of big burns. So again, partial thickness, that's when that top layer is burned. These are really painful. They're red or pink. They'll be a little swollen. Skin looks raw, kind of weepy. Then there's deep partial thickness. Just like what it sounds, it's a little deeper. Swollen, moist, lots of blisters, painful. And then there are the full thickness burns. These go completely through the skin. They may also go through the fat, the nerves, and the muscles. These are really dry. They look leathery. These are not typically painful. Even though when we look at the pictures, we go, oh! But the patient, if the nerves are burned, then the patient really, for the most part, doesn't feel what's going on. Now, they may be taken aback by looking at it themselves, but they don't usually have a lot of pain with it. So what do we do for these? Well, obviously, it depends on how deep the burn is. A lot of it also depends on where is it. Does it cross joints? If it crosses the joints of the fingers or the hand, it's important to have somebody take care of that knows how to take care of burns, because unless it's just very, very lightly burned, if it's just if it's a deep partial thickness burn, then it really needs to go to a PT or an RN or somebody who knows how to take care of burns to make sure that they get splinted in a functional position. Because what happens when a patient is burned or when they have any sort of trauma, they want to move to the position of comfort. And typically the position of comfort is not the position of function, okay? So as therapists, we will always try to position you in a position of function. And so what I mean by that is we will put you in this position so that if you were to heal in this position, you would still be somewhat functional, okay? So you would be able to do this and still be able to pick something up, okay? But if you are not splinted in the correct way, and you are someone who gets keloid scarring and that kind of thing, and you heal in a position that is not a position of function, it is many surgeries to release those contractures and lots of painful therapy, which we would rather get it on the front end and prevent that than have to fix it on the back end, okay? It's interesting, the dressings that have come out now for burns, a lot of them are multi-day dressings. And back when I very first started taking care of burns, really what we used was sulfamylon and Silvadene, and those had to be changed every 12 hours for them still to have that antibiotic effect that you needed. Now you have these silver dressings that the silver is effective for 7 days in these dressings. And depending on where the burn is, I think these dressings can be helpful. But if it is a burn that crosses joints, you need to unwrap that, and they need to be doing range of motion anyway. So you might as well be using something that needs to be changed at least once a day. So, like I said, most of the agents that we use to take care of burns have silver in them. Silver is one of those things that came along about, gosh, it's probably been almost 25 years ago now that Acticoat came out. Maybe not quite, maybe 20. But it was the first silver dressing, and it could stay on for 3 days. You had to keep it moist with sterile water. Acticoat is still available. It's still my favorite silver. All of the studies are based on the Acticoat studies. So when all these other people talk to you about their silvers, they're kind of relating their information back to the Acticoat studies. So I would just prefer to use Acticoat because that's what most of the silver studies were, a lot of the silver studies were done on. We'll just say that. But you can get silver in a variety of delivery systems now. Almost every dressing now can be, you can find it with silver in it. So Silvadene is a nice white cream that usually feels very soothing when you put it on. Again, it needs to be changed a couple times a day because the antimicrobial action of Silvadene is only 12 hours. Acticoat, the regular Acticoat dressings, those are effective for 3 days. There is an extended wear Acticoat, the silver is effective for 7. There is a dressing called Aquacel, which is a carboxymethyl cellulose dressing. Basically what that means is it absorbs a lot of drainage. So if you have a burn that's draining a lot, Aquacel AG can be a good choice. They market it as you can put it on and leave it on for 14 days, and as the wound heals beneath it, the Aquacel kind of curls up on the edges, and they tell you can just go in and cut that off. I've tried it a couple of times. I didn't really like it. It's kind of weird, but that's what they say. And I'm sure that that would work just fine. It just depends on, if it's on the patient's back and they're not looking at it, that would probably work just fine. But it looks kind of funny if it's somewhere where they can kind of see what you're doing. So there are silver powders. Comes in looks almost like a little salt shaker. You can just shake it on. So that's available if you have a wound that it's hard to get other kinds of silver on. There's foam dressings called Mepilex. Those are really nice because those have a silicone back on them, and that's what you put in contact with the wound. So if you know much about silicone, silicone won't stick to anything that's wet. So all you need is a little border of intact skin, and you can put this dressing down. And the nice thing about it is you can lift it up and look at what's going on underneath and then lay it back down. These are very, very comfortable dressings. They're certainly more expensive than a lot of the other silvers. They work great in our kids' population because they don't hurt them. And that's a lot of what you need to accomplish when you're working with kids is if you hurt them and you've lost that trust with them, that first or second visit, it's going to make the rest of your treatment with them a lot tougher. So you want to really be careful about choosing the dressing when you're working with kids. These are just some pictures of the dressings. You can see the Silvadene in the middle there, the Acticoat on the top left, the little powder is on the bottom left, and then the Mepilex, which is the nice foam, is on the top right, and then the Aquacel, which is the one that you can leave on and let it curl up, is in the bottom up. So what does silver do for us? Well, the reps tell you that it decreases the bacterial count at the wound site, cuts down on the frequency of your dressing changes, and before Silvadene, all we had was sulfamylon. A lot of patients are allergic to sulfa, and so all of these silver dressings give you a way to control bacteria without worrying about the patient's sulfa allergy. Blisters is fairly controversial. There's not great literature about blisters, and my staff keeps wanting us to come to some sort of conclusion. It's just hard. They provide a moist dressing for the wound, but if they're broken, you need to get them off. With kiddos, even if they're not broken when you see the child, because a lot of our kids with burns are toddlers, where they have either grabbed a curling iron or they've pulled, gotten to the table and pulled either hot coffee or soup or something and splashed it down them. They're just so active that if they have a blister today, they're probably going to rub up against something or bump into something or whatever, and it's not going to be a blister tomorrow. They're going to break it. So with our kids, we pretty much debride the blisters from the get-go if we can, especially if the patient is hospitalized and we're doing their care under conscious sedation. You might as well just go ahead and get it done right then while the kid's out so that you're not having to do it as an outpatient in 2 or 3 days. And that seems to work well. So if they're broken, get them off, because if fluid can run out, obviously bacteria can go in. So it's a nice, dark, moist place. So get it off of there. Keep that wound clean. So how do you clean them? For burns, a lot of the time, it's just easiest for us to put patients in the shower. Years ago, we used to do a lot of whirlpool. That is completely out of favor now. I don't even have a whirlpool at any of my facilities anymore. This is a picture of Jetox, which is normal saline that is just driven at the appropriate PSI by an oxygen cylinder. So that works really great. It really lifts that kind of yellow slough that a lot of times is on a burn. It'll lift that right off for you, and you won't have to use forceps or thread or anything like that. So that works pretty good. You can also use pulse lavage, but usually the PSI is a little bit high on that. That's similar to what they use in orthopedic surgeries to clean out wounds, maybe after trauma or before they place a nail or something. But it takes a lot of equipment, and it makes a lot of mess with a lot of fluid flying around the room. Okay, so dressings for burns. Typically, you want something that's a non-adherent. So the silicone dressing that I talked to you about, the Metalex, that obviously is a non-adherent. Silicone will stick to the wound. Some of the other dressings will stick if you're not careful. There are things like Adaptic and Wound Veil that you can apply the Silvadene to, and then those typically won't stick to a wound bed. I don't like Telfa. I think Telfa is sort of like the people who market Neosporin. I think we've all been brainwashed to think that those two products are great for wound healing, and I don't like either one of them. Telfa has a nice, slick outer layer, but inside that is cotton. And so what happens is you put that on the wound, and the wound drains, and the cotton sticks. Little old patients will go to the pharmacy looking for something that doesn't stick, and that's what the Telfa, that's what it says, non-stick dressing. But it's not, it does. And I told this story to my PT students a couple of weeks ago, and then I had a lady come in this week for a wound, but then she also had poison ivy, and it was all up on her arm here, and it was all blistered, and it was oozing and everything, and I was actually looking for a Telfa. And of course I had none, because I don't like them. So anyway, so non-adherent dressings, the left is called Mepitel 1. It's a silicone dressing, and I don't know if you can tell, but it has holes in it. and those are fairly large holes. The nice thing about that dressing is you can put that on the wound and just leave it. And you can deliver your topicals right through it. So if you want to use Silvadene, or you want to use Bacitracin, or you want to use whatever, you don't even have to pick that thing up. The holes are large enough that the ointment will get under, and it doesn't hurt. The products on the right side, the Adaptic and the Wound Veil, the way we use these typically is to open that product up and apply whatever topical it is we're going to use to the product, and then pick the product up and put it onto the patient, okay? So that you're not taking a tongue blade or something and scratching back and forth over the wounded area to apply the topical agent. Okay, chemical debriders, this is the only one that we have left. We used to have several ointments that we could put on a wound that would help us get the dead tissue off. And Santil is the only one that's left. This product is fairly expensive. It does work well, but in order for it to work, it has to get to the place where the necrotic tissue and the good tissue meet. Okay, so if you have a wound that has a big leathery eschar on top of it, and you put Santil on it thinking that that's going to help get that off, you're fooling yourself. Okay, it doesn't work that way. It has to get down where the good and the bad meet. So how do you get there? Okay, so what you do is you have to, what we call cross-hatch, or kind of make little cuts in that eschar, and then put the Santil over it, okay? Because when you make that cut, you have to get down to where there is good tissue, okay? So not for the faint of heart. If you don't do that a lot, send them to me. I love to do that. Okay, burns on the face. We don't use silvers on the face because silver, if you've never used silver dressings, sometimes they will leave kind of a black tone in the wound. You don't want that on your face if you're not black. So we don't use silvers on the face. We usually use Bacitracin on the face or in the nose. Okay, circumferential wounds are tricky. You have to worry about, with these patients, them needing an escharotomy. So you need to be careful about pulses in these folks. Make sure that they still have one, and that the limb is not, super swollen. A lot of times when these patients come in with burns, there's a protocol for fluid for them, and so a lot of times they'll get kind of over, and so a lot of times it will go to the wounded extremity, and sometimes they'll have to go emergently to the OR and just kind of make a slit in a couple of places, and then it'll just open those wounds up where it's not cutting off the blood flow distal to the wounded area. Okay? All right, we talked a little bit about nutrition. Some of the things that are easy to recommend is, to ask the patient if they're taking a multivitamin. And if they say no, then my next question is there any reason why you can't? Because there are some medical conditions where you don't want a lot of these extra things floating around. You got to wonder about their kidneys and different things. So always ask if there's a reason why they're not. If anyone has told them not to take one before you say, oh yeah, go down to Walmart and get you some one a day. And then we talked about protein. We didn't talk about protein drinks, but those are great. Carnation Instant Breakfast is great. Those things that are already packaged and ready to go, especially for patients who are home alone during the day and are not real mobile, can't get up and make themselves a sandwich or whatever. I've had spouses that will just put a cooler next to the patient and put, their Ensure, their Carnation Instant Breakfast, their high protein pudding, their Boost, all of that in the cooler next to them. They'll go off to work, and then the patient at least has those things close to them that are important for them to be taking in during the day. So what happens after the burn is closed? This tissue will itch like crazy. They can use Benadryl, a lot of times just a package of peas over the top of like a towel or something. That'll help with the itch a lot. What we find with kids is that at night when it's itching, they will scratch, they won't even really know it. It'll happen in their sleep. So a lot of times we'll tell parents, please go ahead and put them in long-sleeved and long pants, pajamas to sleep in for a while until that tissue is not quite so itchy. You have to moisturize it like crazy. We have some things that we recommend, but basically what we do is we teach parents and patients to read the label. So if you're reading the label on the back of the product that you want to use for moisturizing, make sure that alcohol is no higher than number 6 on the ingredient list. If it gets much higher than that, it will actually dry things out rather than moisturize. Creams are always thicker and better than lotions. So if there's a cream that someone likes, that's what we ask them to use. But things like Eucerin, we'll use sometimes Aquaphor. For patients who can't afford anything else, we've actually used Crisco. So just anything to kind of lock that moisture in. Now we suggest that they do go get a new can of Crisco, not to use the one that's in the cabinet that they've been cooking out of. But it doesn't always have to be something expensive, especially where I work. Most of the patients that I see are underinsured. So we've got to go with what is available and cheap. All right, so just kind of to sum up things for burns, we want a silver dressing just to keep it from getting infected. We want something that's not going to stick. We want to make sure that the family understands range of motion exercises. We want to refer to a therapist that can help them with that. We want them to eat well. And we want them to understand that this tissue is not going to be the same as it was before, and so we have that whole sheet of aftercare instructions. Sunscreen is critical for these folks. I'll tell you guys how my husband and I got together. He was a drag racer, and he was racing his motorcycle, and he went down the track after a real quick rainstorm. So you guys know how when it rains and the oils come up from the okay, so that's what happens. So he goes through the lights at about 110 miles an hour. The light flips over, and he skids along the ground for I don't know how long. So he came to me as a patient with road rash everywhere. I mean, he was covered, and my husband is a mechanic, and so he has very thick calluses on all of the pads of his fingers and thumb. And I don't know if he drug them on the ground or if he grabbed the pipe, but all 10 of his fingers had blisters on them. So anyway, got him well, and about 2 weeks later he came back to the hospital and asked me on a date. However, he is dark hair, blue eye, okay, a little bit of freckles, so you kind of get the picture of what kind of skin he has. So he had an area on the back of his shoulder that wasn't very deep. And it was one of the first things that got well. But for 10 years after that, that area burned every time he was in the sun. And we tell folks that it's 2. 2 years and these scars will be matured. So anyway, just for kids, sunscreen is just so important after they've been burned. Something that is really high SPF. Okay? All right. Do you want, yes?
So it says that the silver technology is good for people who have salt allergies, but Silvadine has sulfa in it?
Yes.
So do the other ones?
No.
Okay, so you would use...
Yeah. So, the Aquacel AG, or the Arglaze powder, or the Acticoat, or the Silver Lawn, none of those have any sulfa in them. Okay? Okay? All right, do you guys want to stand up, jump up and down, go to the bathroom, break?
Make it quick though.